Welcome. I'm glad to be here. Thanks, everyone. Dr. Lin, I'll turn the time to you to speak in Vietnamese, introduce this case, and then we will discuss it and take questions. And I have some other adrenal slides that we can look at after we've reviewed this case as well for comparison.
Chị giới thiệu lại ca này, bệnh nhân nữ 47 tuổi, cũng có cái tăng huyết áp không phải thường xuyên mà thỉnh thoảng mới có cơn tăng huyết áp. Thế, cũng phát hiện cái khối u ở bên tuyến thượng thận bên trái. Cái ca này mới đầu xem thì cũng hơi cái, cũng hơi tắc hộ ở đấy. Thì là mới đầu nhìn thì cũng thấy là cái cấu trúc nó cũng hơi đặc biệt. Nhưng mà nhìn kỹ thì thấy rằng là cái khối u này nó có cái vỏ khá là rõ, có ranh giới khá là rõ, có chỗ thì có vỏ sơ nhưng có chỗ thì ranh giới rõ với cái tuyến thượng thận ở phía ngoài bên lành bên này. Thì, cấu trúc u thì đa hình thái, đó là có những cái vùng nó mật độ tế bào nó nhiều hơn, có những vùng mật độ tế bào nó thưa hơn và cái mô đệm nó phù hơn. Thế còn cái tế bào bình thường ấy thì Ờ, có hai cái nhóm là u vỏ thượng thận và tủy thượng thận. Thì cái vỏ thượng thận thì tế bào tương nó sáng hơn, nhưng mà trường hợp này thì trong nó thì nó cái bào tương nó lại ái toan, nó hơi đặc biệt. Nhưng mà mình quan sát kỹ ở cái vùng vỏ thì có một số vùng thì cũng nghi ngờ cái xâm nhập cái vỏ ở cái vị trí này, hoặc là ở cái vị trí cái vỏ nó mỏng hơn, nó bóc tách cái lớp vỏ sơ ở đây ra những cái thành những cái đám nhỏ hơn, nhưng mà nó chưa vượt quá cái vỏ sơ này để ra cái mô đệm phía mô mỡ mà mô mỡ phía ngoài của tuyến thượng thận. Nên là cái trường hợp này cái đánh giá cái thang điểm PAT mà xâm nhập vỏ ấy, thì nó cũng hơi lăn tăn cái vị trí cái chỗ này. Thế còn đấy như lúc nãy tôi nói là nếu mà u thượng thận mà tuyến vỏ thượng thận thì là cái bào tương nó sáng hơn, dạng sáng hơn. Thế còn trong hoặc là tủy thượng thận thì là cái bào tương dạng hạt và ưa kiềm. Nên trong trường hợp này thì lại thấy rằng là tế bào u lại ưa toan. Thế là bào tương nó ưa toan rất là rõ. Và hình thái nhân thì là cũng atypical, nghĩa là đa hình thái hơn. Tính chất nhân thì có những hạt nhân rất là nổi bật, rất là to và nổi bật đây. Thì cái này thì mình là tính là cái đa hình thái của nhân. Đây cái bào tương nó cũng ưa toan rất là rõ, bào tương rộng và ưa toan. Thế có những cái gọi là tăng tuyến tiết ở đây này, dạng như là globin thì nhìn mới đầu xem lại thì mình mới xác định được đây là cái đặc điểm của trong cái u tủy thượng thận. Cái nhân đấy cũng đa hình thái rất là rõ và hạt nhân nhiều, tế bào hạt nhân rất là nổi bật. Thế là cái sự đa hình của nhân. Thế nhưng có những cái vùng khác thì lại bào tương dạng hạt giống như là sáng và dạng bọt, giống như là cái tế bào bọt ấy. Và cái là cái hình thái của u nó không đồng nhất về mặt tế bào, nó có nhiều vùng về tính chất tế bào nó khác nhau. Thế còn có u thì cũng có cả cái vùng hoại tử ở trung tâm lên nữa. Thế này nhìn kỹ thì mình cũng sẽ thấy đó, nó chỉ còn một vài cái nhân đông ở trong cái tổ chức hoại tử này. Thế cái hình ảnh mà xuất huyết trong u cũng rất là rõ, là xuất huyết và kèm theo thì hoại tử những cái từng ổ nhỏ một. Còn trường hợp này thì nhuộm với hóa môn miễn dịch thì dương tính với CD56 và NSE. Thì CD56 là dương tính mạnh lan tỏa, còn NSE thì là dương tính ổ thôi. Thế còn các dấu ấn khác thì đã làm thì melan A âm, BAT 8 âm, M100 âm, TTM1 âm. Thì trường hợp là mình tại sao lại nhuộm TTM1 vì cái hình thái nó hơi đặc biệt, thì cũng mới đầu cũng nghĩ là di căn và tuyến thượng thận thì thường là di căn của phổi đến tuyến thượng thận là nhiều, nên là mình cũng làm để gọi là loại trừ. Và khi 67 thì trong trường hợp này cũng dương tính rất là ít, nó chỉ có lác đác các tế bào u dương tính với khi 67 thì đánh giá là dưới 1%. Là mình đến trên một cái vi trường này 10 tế bào thì nó chỉ có một tế bào dương tính thôi, thì gọi là dương tính khoảng tầm 1%. Thế cái ca này thì sau kể cả phân tích kỹ lại về hình thái và kiểu hình hóa môn miễn dịch thì nghĩ đến cái u tủy thượng thận PO pheochromocytoma với cái thang điểm PAS score ấy là khoảng 6 điểm. Cái này thì thực ra tính tính cái thang điểm này cũng một số cái điểm lăn tăn là cái chỗ xâm nhập vỏ với cái
Ủa, Linh tắt tiếng rồi, không nghe thấy đâu.
Did you find any mitotic figures? Dr. Lin? Oh no.
Linh bị mất tiếng rồi.
Uh,
Xem mic chắc bị
yeah.
tắt rồi. Maybe audio is turned off. I cannot hear.
She come back yet? So when I looked at this case, I looked very, very hard for mitotic figures, and I could not find any. This is not coming into, oh, here we go. The presence of nuclear pleomorphism is not a good criteria. It's not a criteria for malignancy because we can see bizarre nuclei like these in benign adenomas or in myelolipomas or other lesions. I do think this is an adrenal cortical lesion. It does not look like a pheochromocytoma. It does not look like most carcinomas. It has some of these clear spaces that almost look like fat. And so one wonders about myelolipoma in the differential as well. Dr. Lin, you're back. Would you like to say anything more about this case? Do you have more slides to show?
So Dr. Linh thought that her internet have a signal very weak.
Okay. Okay.
She come back. She come back. Okay.
Yeah.
Yes, Professor. The
Do you have more
internet is,
PowerPoint slides to share?
I say PowerPoint for all member. Yeah, so you can show the other picture from my link.
Okay.
I send you. Yeah.
All right.
Yeah.
Let me go to the other slide here. Oops. No, I want to go back to the other digital slide. So I was uncertain about capsular invasion because this slide that you sent me has this here is these are residual normal adrenal cortical cells in this compressed capsule. And I was not I did not see slides where I had definite capsular invasion, but I was concerned about that. I'm a little bit annoyed by the lack of mitotic activity and Ki67 result being quite low. Can you tell me how large this tumor was? Dr. Lin,
Tuấn Tuấn
how many centimeters?
What?
kích thước của khối u bao nhiêu nhỉ?
With me some you can match.
Khuôn nên các lớp tính không thể có được, không cho vào được.
Đại thể có kích thước khối u.
So I thought it would be helpful for us to review the Weiss criteria. And I'll tell you the story about this. Dr. Weiss is about my age. He was a resident at Harvard at the same time I was, a little bit ahead of me. And he was a very talented surgical pathologist, very bright and very hardworking. But the story behind this is a little bit unusual because Dr. Weiss, to develop his original criteria, which were based on a number of adrenal tumors that had either metastasized or not metastasized. So he was taking clinically malignant tumors and comparing them to tumors that did not metastasize, and looking at the nuclear, all of these features. And so he came up with all of these original findings being significant for lean towards risk of metastasis. So high nuclear grade. This is not nuclear pleomorphism. This is overall nuclear grade. Mitotic figures, atypical mitotic figures, the clear cells, or what you've called foamy cells, that are 25% or less, diffuse pattern, architecture, necrosis, areas of vascular invasion or sinusoidal invasion within the adrenal, and then things like capsular invasion and so forth. So each of these was given. So the thing about his study is that he did it entirely himself without any mentoring from any of the senior pathologists in the department. And he submitted his study, it was accepted and published. And needless to say, there were several people who were critical of the way he'd gone about this, working solo without any consultation and so forth. It seemed very presumptuous, and therefore it was highly criticized. And so then you have additional material and other people coming back, and he revisits these with more cases and comes down to these criteria. Mitotic rate, very important. Clear cytoplasm, less important, and certainly not applicable in the oncocytic tumors. But abnormal mitoses, necrosis, and capsular invasion. So these are fairly standard criteria for malignancy in many neuroendocrine organs or endocrine organs as well. And they seem to be the more reliable ones. So even though we like to find some of these things and they may help us, by all accounts, it's these criteria that we use for the most part. And so when I looked at this case, I didn't see in any of these high magnification views any mitotic figures. You showed some area that you thought saw necrosis, but I didn't see that. I guess this is what you thought was the necrosis here. So let's take a look at this and see if this is truly necrosis. Usually, when you get necrosis, you have nuclear debris and karyorrhexis. I think it's possible that this is rather an area of hemorrhage, and this is fibrin rather than necrosis. So again, I am a little bit reluctant to call this necrosis because all I see here is the pink tissue, red blood cells, and a few scattered viable cells here. So I think this may be simply an area of intratumoral hemorrhage rather than intratumoral necrosis. I looked in areas like this, over here, again, looking for mitotic activity. And I didn't find any. So now it's not to say they aren't there because I can't really go to ultra high magnification. But I did not definitely find them. Now, one of his minor criteria is invasion of the sinusoids. This is certainly a diffuse pattern. And we have lots of clear cells. So that probably would be a negative criteria on there. Maybe this is a mitosis. I don't know for sure. So prior to Dr. Weiss's criteria, size was a predictor. Larger tumors were more likely to be malignant and to spread. And I think the cutoff was somewhere around 7 or 8 centimeters. Was this case larger than that?
Professor, this tumor about 7.5 centimeters.
With only 5 centimeters?
5 centimeter diameter.
Could you write that number in the chat? I'm not sure I heard the first digit.
It's about 7.5 centimeter.
Oh, okay. So that's right at the cutoff between benign and malignant cases. So capsular invasion, if that's present, again, I would lean towards carcinoma. But the other criteria, I'm not so sure about. Now, this area, let's see if is this necrosis here. Well, again, I don't see any karyorrhexis here. Hormone function is not a useful criteria. It sounds like her hypertension may have been related to this tumor. Sometimes these foamy tumors or foamy cells are aldosterone secreting cells or other glucocorticoid cells that are responsible for that. I do think it's a little bit unusual we have so much fat in this case. So let me excuse me. Let me share a couple of cases that I think are good examples of adrenal cortical carcinomas. So here is a case, and this has several criteria that I think are fairly useful. First of all, we can just go and see the number of mitoses here. There's one. Here's another one. Here's another one. And I found these mitoses in about 5 minutes. So these are all quite close to each other. If we sort of back out here, we're all pretty much in this region here. There's another one there. Here's another one here. These are maybe a little bit more suspect, but a lot of band light. They're not atypical. And there's another one. Like the area that we had in our case, we do have some residual adrenal. And here you can see the nice foamy clear cells of the cortex. And then we have tumor pressing around it on sort of on two sides. In this case, I had to hunt, and I was only able to find a few areas of tumor necrosis. But this is, I think, good for tumor necrosis because you have cytoplasmic and karyorectic debris here. See all these very dark cells in here? I think this is a small area of tumor necrosis. And these were, in most cases, microscopic. So they weren't broad geographic necrosis types of cases. Now, the last criteria that would be a minor criteria is evidence of sinusoidal invasion. So this tumor had quite a lot of this trabecular pattern with dilated, widened sinusoidal tissues. And there were a few areas like this, where you have this little block of fibrin. Here we have endothelial cells here on this side, over here on this side. And then right here, there's no endothelial cells. It's just fibrin and then tumor cells. I think some people would regard this as sinusoidal tumor invasion. Certainly, it exposes the tumor cells to the lumen and makes the possibility for spread a little bit higher. There were several other areas like that. Here's another area of fibrin. I think there were some other areas. Let's see if we can find another one here. Because once you see one, and then others will sort of jump out at you at low magnification. Well, maybe here is one where you're getting a little bit of organization of the fibrin there. But I think that's a hard criterion to apply, and I think that's why it's not in the modified criteria, is that it just doesn't, it isn't helpful that often, and so not including it was not a big loss. Let me go to another case and show you a little bit here. I think we have some annotations here again. Here's another example of necrosis. So here you can see the little ghosts of the tumor cells, some karyorexic debris, and so forth. I think this is a nice area of necrosis. Now notice that this is a very oncocytic tumor. There are no clear cells, but that's not a criterion to use for malignancy in the oncocytic tumors. Here's another focus of necrosis, not quite as dramatic, but again, you've got a lot of karyorectic debris, cell debris, and then it's fragmented here. So it sort of goes around here. Now, in this case, I had difficulty finding mitoses with this. And so if I have a large tumor and I've got necrosis, but I don't have other criteria like capsular invasion. It's an oncocytic tumor. I might do, in addition to Ki-67, I sometimes use the phosphohistone 3 or PHH3 immunohistochemical stain. This is a marker that only stains cells that are in mitotic phase, that are in that active division stage, and therefore usually can be counted as mitotic figures. It stains the separated chromatids because that's when the phosphohistone 3 antigen is exposed. So that's sometimes a useful adjunct tool in these kinds of cases. Another example here is very pale staining. And again, I've highlighted some areas. Here you see we have a rim of normal cortex. As we look at these cells, these are fairly high-grade nuclei. These are probably Furman grade 3 kind of category, fairly evident nucleoli. Not a lot of clear cells. This isn't really oncocytic, though. But you can see we have mitotic activity even as we just sort of wander around. Here's another one over here. So mitoses, this readily identified 2 in 1 less than high power field, would most likely indicate that you're dealing with a malignant neoplasm. But you can see I've highlighted lots. This one may be even an atypical one. There's another one, slightly atypical. Another one. Now, the issue of capsular invasion here is sometimes difficult, as with the thyroid. But I think this area here shows a nice example of the capsule here with the normal adrenal cortex over here, tumor up here, but penetration of tumor into this fibrous capsule. So you can see the fibrous capsule here on both sides. As well, we see maybe we may have here some degree of vascular invasion. It's sort of bulging up towards it. I don't know that we're right into the lumen, but we're certainly looking suspicious for capsular or for vascular invasion as well. And here's another area here where, again, the tumor has thinned out, something that looks like it could have been capsule and is pushing into a space. And here there's an interruption. So right here, this is capsule, and then it's broken, and the tumor has extended out over it. So that's another good marker for capsular invasion. And perhaps to underscore that, you may even have a few normal adrenal cortical cells here in that capsule. So those are the features that I wanted to sort of help you see as we evaluate adrenal cortical neoplasms. One more here. This one is quite obviously out into the fatty tissue. There's no residual cortex here. We can look here, but it's formed a new fibrous capsule as it's extended out into the fat. And this lymphatic or lymphoid inflammatory reaction helps to underscore that. In this case, I could not find much in the way of necrosis. We do have a fair number of sort of clear cells here. Let's see if we've got no annotations. Okay. So I'll leave this one and send you the link to these so that you can come back through these and review them as well yourselves to look for this. This is a very challenging diagnosis, adrenal cortical carcinoma, and I think that's why you shared your hard case. I think because it is a hard case, and we don't see enough of these in any one institution, usually to make good get good exposure to these criteria. And that's the value of a teaching set like this, where you can look at several cases, more than you're usually going to see in regular training setup. Now, if we compare this to, say, a cortical adenoma, which is what this case is, we can see a number of different features. One is here, there are lots more clear cytoplasm. These are almost all clear cytoplasm cells. The nuclei are lower grade. Of course, because the nature of adenomas is that sometimes they're associated or come out of a hyperplastic cortex, sometimes the boundary between normal and adenoma is difficult to define. So we may have areas, could this be a normal cortex and then this be adenoma? It's hard to tell. But certainly you want to look at an area like this to say, is this necrosis? Well, no, it looks like these are just more oxophilic cells. And again, low nuclear grade, no mitotic activity, no necrosis, and hopefully we don't see capsular invasion. So you might say, well, is this capsular invasion here? But we know that the normal adrenal is somewhat wrinkled. And so here you've got cortex and a little more almost medullary type tissue there, variable cellularity, variable cell types. And that all argues for a more hyperplastic or adenomatous type lesion. Here's another, whoops, this is not the right case. This is not from the adrenal cortex. So I should have deleted that case because we've got here urothelial tissue. We're in the bladder, and we've got carcinoma here. So this is a bonus case that I wasn't going to talk about, and I won't spend any more time on that. Now, the other thing we considered was the diagnosis of myelolipoma. And by and large, we don't see these sampled any longer, primarily because the radiologists are quite adept at making this diagnosis, and on the CT or MRI, especially MRI, because they get this nice fat signal in the adrenal that tells them that they have a fatty lesion, and that's almost universally associated with myeloid elements, which, as you can see here, is a mixture of hematopoietic cells that includes these pleomorphic or megakaryocyte cells. Now, those can sometimes look like the bizarre pleomorphic neuroendocrine cells that we saw in the lesion earlier. You can see they look bizarre, but it's what they live with. So they're living here with red cell precursors, with granulocytic precursors, and so forth. And if you have any questions about that, you can do a myeloperoxidase immunohistochemical stain, or maybe a CD117 or CD34. You should be able to identify some hematopoietic blasts using one of those stains that would inform you that this is a hematopoietic lesion. Here's another example. This one, you see the architecture a little bit better. You see here's our normal adrenal cortex, and here in the medulla, the medullary area, is this fatty lesion that is intermixed with cells. And we see the eosinophils. Here we see a megakaryocyte or two and three, and erythroid precursors as well. So not really a diagnostic problem, and less and less likely to be a surgical pathology type of specimen because of the radiologist's ability. These have a completely benign course, no association with leukemia or lymphoma or anything of that sort. It's just essentially ectopic hematopoietic tissue that comes to live in the adrenal. So let me stop there for a minute and see, do we have any questions that anyone wants to bring up about these lesions so far? I have a few other lesions that we can talk about in the adrenal as well, but I want to see if we've covered the adrenal cortical differential well enough. You can write your question in the chat or ask it verbally if you'd like.
Professor,
Dr. Doe? Yes.
how about different between cortical adenoma or medullary adenoma of under
So I will talk about the pheochromocytomas and the
yeah,
ganglial tumors that occur in the medulla.
yeah.
Yes, we'll talk about those here in just a minute. Okay, well let's go back to those, and I'll share that portion of my presentation again, and we'll go to the next slide, which. So with pheochromocytoma, again, the differentiation of benign and malignant is difficult and rests upon some of the same features that we've seen in adrenal cortical lesions. But in terms of behavior, in fact, the secretory product, the norepinephrine, is oftentimes the bigger problem than the presence of tumor masses in other organs, because this is what's going to probably kill the patient rather than tumor overload in the liver or someplace like that. But tumor size and weight are features that, again, help to lean you towards malignancy. Higher size, higher weight, those are all things to favor malignancy. Invasion of the surrounding tissues, mitoses or atypical mitoses, and necrosis, as we've seen. So the same features, invasion, mitoses, necrosis, atypical mitoses, those that we saw in cortical carcinomas, are also a potential concern with pheochromocytoma. Having said that, malignant pheochromocytoma is really very rare. I think maybe I have seen one or two in my life in terms of clinical practice, and that's in a fairly busy academic setting that would get these kind of cases. So I don't think that you should see one of these, more than once in most cases. Again, higher Ki-67. And if you're able to do molecular analysis, many of these cases will have RET mutations, von Hippel-Lindau, or SDHB mutations. Now, I don't know that any of these examples that I'm going to show are malignant. I think not. I think these are all just pheochromocytomas. What would we expect to see? Well, as we did in the cortical lesions, we should see some cortical tissue. And sure enough, here's the cortex. Here's some compressed cortex out here. And then we have something that looks different. And you can see the difference here, the very coarse, granular, almost ropey cytoplasm of this tissue compared to the various layers of the cortex. So this is clearly growing in the medulla. It looks different from the cortical tissues. It doesn't seem to be highly compressing the cortical tissues, so you don't see, a real marked thinning of the cortex here as we go around this lesion. There's a little bit of fibrosis here, so there's a little bit of mass effect. Here's some pleomorphic cells, but as we've indicated, this kind of nuclear pleomorphism is not a reliable criteria to predict either molecular genetic or malignant behavior in these neuroendocrine tumors. But it is certainly striking. You see a cell like this and you go, wow, that's really ugly looking cell. Now, these tumors are very vascular. I mean, that's how norepinephrine gets into the vasculature, is because of this very close arrangement with the cells, the medullary cells. And that's critical for our response to stress and to painful situations, to have that rapid release of these cells. Now, when I was a resident, before we had immunohistochemical stains back in the dark ages, we actually did histochemical stains on this kind of tumor using potassium permanganate. If you can believe it, we would just take a little piece of tumor, soak it in potassium permanganate, and it would react with that because of the aldehyde groups in this tumor. It would reduce that, and it would stain the tissue differently than the normal cortical tissues, which would not have the granules or the aldehyde groups exposed to reduce the permanganate. I don't think I did any annotations here. No annotations. Okay. I have another example of this lesion as well. So here we can see a nice capsule. And we can see, here it is. This is adrenal cortex that is compressed. So these little clear cells, little chains of cells here, are adrenal cortical cells that are sort of fighting for their survival amid the wild growth of this pheochromocytoma. And here you see the very characteristic, bluish granular cytoplasm, some considerable nuclear atypia and pleomorphism. Again, not an indicator. Maybe here's a mitosis. And if we saw very many of these, well, maybe here's another one. We might wonder, could this be a malignant lesion? And again, that's why I would probably do the PHH3 to verify that some of these things really were mitotic figures and not just pycnotic nuclei or degenerating nuclei. So something like this, you can't really tell if this is a pycnotic nucleus or mitosis. Now this has this nice Zellballen characteristic growth, rounded nests of tumor cells with potentially surrounding sustentacular cells in a very vascular network. So you could do S100 here, and that would stain these cells. It's not critical, but certainly could be supportive of your diagnosis. Now notice here that we're starting to get a degree of neural and gangliocytic differentiation here. So this is sort of neuropil type tissue. Here's more of it over here. And you might wonder, is this necrosis? It could be. But this is all a neurotization of this lesion. It's developing a neuronal differentiation, and you're getting this kind of pseudo-necrotic or necrotic type of appearance in this lesion. So this is not in itself either suggestive or not of malignancy, but it is if you have the necrosis, and then that would, again, make us wonder. And of course, we've seen that we have a number of cells that look like this, where we could be looking at atypical mitotic figures. And so this behavior with the neuronal type of differentiation, this glial pattern, and the presence of apparent ganglion-like cells in this mix is quite interesting illustration of what these tumors can do. And you can see here it's quite extensive. So there are some other features that can be useful in this, and we'll go look at those in just a minute. Here's one more case, more normal area down here, cortex, medulla, medullary tissue. And then we have here neoplastic tissue, which looks more like the medulla. Again, you have a few cells that look like they could be mitoses. So don't hesitate to do the PHH3 or Ki67 if that's going to be helpful to you, or if it's indicated for the patient's diagnosis. Notice here we get some sort of melanocytic type of pigmentation, dark, almost missile substance like granular brownish material in the cytoplasm of these cells, in contrast to the hyaline globules that we saw in the cortical tissues. Some of these tumors can be quite darkly pigmented, even to the point of appearing like melanoma in some clinical settings. So what are we looking for with pheochromocytoma? Well, I'm going to skip this case because it's just a reiteration of that earlier case. So these are the scoring system that's used in pheochromocytoma. Oh no, let's see, I've lost my window here. Let's see if we can pull it up. I'll share the PowerPoint and let you look at it there. And we'll go to so you can see there are some of the same things that we were looking at before. My computer is slow. taking a minute to get to the presentation mode. So we're looking at invasion, and that gets, let's see, are you seeing presentation mode or the? Okay, now you should be seeing the right screen. So invasion, mitoses, atypical mitoses, necrosis, spindling. They score pleomorphism. These sorts of things. Whoops. So these all are scored with greater than 4 being concerning for malignancy. And note that some of these are very subjective. So if I was, say, only seeing a lesion that had marked nuclear pleomorphism, capsular invasion, hyperchromasia, 1-point lesions, I might be a little bit careful if it's very subjective. I think these first ones are the more reliable criteria. Now, similar criteria have been proposed for paraganglioma. And so I've put this chart in here as well for you to refer to, which includes features like histologic pattern, chemetonecrosis rather than just any necrosis, a Ki-67 gradient score, meaning less than 1% is 0, 1 to 3 is 1, greater than 3 is a +2, and then the functionality of the lesion. So these help you to define a degree of differentiation, but may also be predictive of behavior on the assumption that the higher grade tumors would be more likely to be more aggressive. So I'm going to stop the sharing there, and I'll take any questions that anyone wants to have. Question there, could eosinophilic cells be seen in pheochromocytoma? Well, they're not very common if they're present. I don't think I have seen very many. Usually they are that bluish gray purple color rather than eosinophilic. And so I'm a little bit less likely to believe that there are very many, that it's very often. Any other questions? Well, I will include the link to these digital slides. There's also a few other things in there. I've got a ganglioneuroma and so forth. Just to remind you that the adrenal, especially in the pediatric age group, can be the site of neuroblastoma. And neuroblastomas have a relationship with pheochromocytoma, also with ganglioneuroma and so forth. So that's a consideration if your population is children. And then beyond that, it's more common to see metastatic tumor there than it is to see primary tumors of the adrenal. So usually we're looking at metastatic carcinoma to the adrenal rather than a primary adrenal cortical carcinoma or a malignant pheochromocytoma. It's a fascinating organ, and we're grateful that we have them. We couldn't survive without them. And fortunately, they're small, and the number of times they present diagnostic pathology problems is lower than other organs. But that also makes them more challenging when we do see them.
Thank you.
So any questions?
No.
All right. So we next month would be Christmas, but I could do a session with you on January 3, your time, January 3, just after the new year, if that would work. We could do another session then. If not, we will wait till the end of January. So may you
Yes.
have a very happy holiday season ahead as you maybe if you celebrate Christmas, if you don't, as you prepare for debt in the early part of next year.
Yes. Thank you, Professor.
Okay, good to be with you.
Yeah.